Good evening and happy Wednesday. Welcome back to Health Plus Weekly. Thank you for joining us. Thank you everyone who tuned in last week and for making our show so successful. Again, if you like the show, please share it along with your friends so we can increase the awareness and the participation in the show. We have a great program tonight. Joining Hannah and I is Dr. Curtis Mello. He is a pulmonary, critical care, and sleep medicine physician who grew up in the area, has been practicing in the area for over 24 years. And the topic of tonight's show, we're going to start off with, is actually talking about sleep. Kurt, one of the topics of the past month has just been about New Year's resolutions, kind of getting back on track. So we had physical therapy, talking about kind of exercise and injuries that kind of come with it. We had nutrition, talking about diets and just information regarding do's and don'ts. And as a primary care doctor and and a clinician like Hannah, I see we have tons of questions about sleep. Sleep is super important in terms of our overall health. We were just looking up some data beforehand. Supposedly 30% of adults report sleeping less than 6 hours a night these days. And 19 to 50% of people suffer from insomnia in some way or another. And it's just, I think people underestimate how important sleep is. And we just wanted to maybe talk about, first of all, introduce yourself and talk about why sleep is so important for our bodies.
Well, thank you for having me. Sleep is incredibly important for all aspects of our lives. So first of all, it's incredibly important for just our psychological well-being. There's a lot of data linking sleep deprivation with certain psychiatric disorders. Sleep deprivation has also been shown to worsen cognitive function. Some people become very forgetful, they don't do well at work. Sleep deprivation may be associated with hypertension as well. Also weight loss. So people who are chronically sleep deprived actually have difficulty losing weight and usually gain weight. So there are a lot of ways that sleep impacts our lives in a negative way.
I always try to tell people it's I think an internationally recognized form of torture, sleep deprivation.
Yeah.
You're right? I mean, in a way,
Yeah.
not to underestimate. I see young parents with children. One of the women in my office, we were talking about, her son hasn't been sleeping for 2 years and finally has started to sleep again, and she just can't believe how much better she's feeling. And it's ironic, she's actually lost weight. Like willpower comes back because it can affect your choices, right?
Well, actually, there were hormonal changes that occur that favor weight gain once you're sleep deprived for a period of time. So our ghrelin levels, which is a hormone that makes us want to eat more, goes up, and leptin, which makes us feel satiated, goes down. So the imbalance is in such a way that people tend to consume more calories, and in particular, carbohydrates.
Okay. How much sleep should we be getting?
Well, it kind of depends. The average individual needs somewhere in the vicinity of 6 to 8 hours of sleep at night.
Okay.
If you're younger, you need a little bit more.
Mm-hmm.
The kids and the teenagers need more sleep, and as you get older, need a little less sleep, but that 7 to 8 hour range is probably the sweet spot for most people.
It's kind of like a bell curve.
Yep.
How do you know if you're getting enough sleep? Like, does it depend? I've heard, like, you should wake up. Should we wake up before our alarm clocks, or or is it, you feel rested, or how do you know?
Well, part of it has to do with just your circadian rhythm, right? So we have this intrinsic rhythm that our brains control that tells us when we want to go to sleep and when we want to get up. And that's highly regulated to about 24.1 hours. Okay. Very tightly regulated to the clock. That being said, though, as long as you're feeling well during the day, you're not sleepy, you're functioning at the level you should be functioning at, you're probably getting enough sleep if you're in that range.
Okay. Children?
Children need more sleep. Think about infants. They probably sleep around 18 hours a day. When your kids were little, that's all they did was sleep. Yeah. That's normal.
Yeah.
And as you go through time, you lose some of your slow wave sleep and you start to get more REM sleep. And there's a natural progression, if you will, or evolution of sleep architecture as time goes on.
Okay. This actually kind of leads to another question. I think we hear about REM sleep and the phases of sleep. Can we talk a little bit about just basically what that means?
Sure. So there are, think of human beings in two stages, right? Or two states. A, we're awake, or B, we're asleep. So when we talk about sleep, there are essentially 4 stages of sleep. And you can divide those even easier into a light sleep, and a deep sleep, or REM sleep and non-REM sleep. So non-REM sleep is considered light sleep. There are 3 stages there, 1, 2, and 3. This N1, N2, and N3. So in N1 and N2, typically we are in a very light sleep and probably aware of our surroundings. Once we get into slow wave sleep, or in a deeper stage of sleep, now our muscles start to relax. It's important, and we get most of that early on in the night. Once we enter REM sleep, that is a different type of sleep. That's an active sleep.
Oh.
And what I mean by that is the brain is very active. However, our muscles are actually paralyzed. The only muscles that work are obviously our respiratory muscles in our eyes. Other than that, we're actually paralyzed.
Huh.
But that's where our brain reprocesses all of the things that have occurred during the day. That's where dreaming occurs.
Oh, really?
Yep. That's how you really feel rested, is when you get your REM sleep.
So it's
Okay.
not just the quantity of sleep, it's the
No.
quality of sleep.
So there are, yeah, and as the night goes on, you get more and more REM sleep. So then there are a cycle is all 4 of those stages for the most part. And the average human being probably sleeps 4 to 5 cycles a night.
Okay.
And if you look at the sleep studies, those REM periods get progressively longer.
As you get older?
No, in
Oh.
terms of each stage,
Oh, okay.
each cycle. So
Okay.
later on in the night, we get most of our REM sleep. That's why a lot of us will remember our dreams in the morning,
Oh, okay.
because we're probably waking up from REM sleep.
A couple questions coming in here. First one is from Laura. Any tricks to getting more sleep? I'm sleeping about 6 hours. Problem is falling asleep around 9 o'clock p.m., waking up by 3. So no trouble falling asleep, but trouble staying asleep, which is kind of one of the things that we talk about in primary care. Do you have trouble falling asleep or staying asleep?
Yeah, part of that, I hear that complaint a lot. And really, what people are doing, and it's very problematic in the elderly population, is that that's called advanced sleep phase. So basically, they're pushing their sleep phase a little bit more. It's probably going to bed a little too early. So what we tell patients is try to go to bed no earlier than 10, 10:30, 11, if you're going to wake up at 6 o'clock. Because if you do the math, if we're saying you need somewhere in that 7 or so hour range of sleep, well, if you're going to bed at 9, you expect to wake up around 3 or 4 in the morning.
So just kind of pushing the
You have to
bedtime
push,
back.
you have to push the clock, yes.
Okay.
And correct me if I'm wrong, but I've read that how much sleep we need is a bit of a bell curve, right? Like you said, like some people require more sleep and some people may require less sleep. And so I think some people get caught up on they're not getting enough hours, but they might just be getting enough sleep for them. Like you said, like if you are getting through your day and you're thinking fine, you're not nodding off, you might just be one of those people who are very fortunate to not require as much sleep.
Yeah, there's about 3% of the population of what we call short sleepers. So they need somewhere in the vicinity of 5 to 6 hours of sleep at night, and they function fine.
I'm jealous. What's next, Hannah?
Another question, and this was something that we had talked about earlier. What are some kind of natural sleep remedies that you offer up to people, kind of as suggestions prior to any type of prescription sleep aid? Like what, if somebody comes in, with a sleep problem, what do you kind of go through as your suggestions?
So I try to get a good understanding of what's going on prior to going to bed and what's happening once the person gets to the bedroom.
Okay.
As the night goes on and we're getting ready to go to sleep, all of our systems are supposed to slow down. Even what we're thinking about is supposed to slow down. And by the time you get up to your bedroom, you should be ready to go to sleep. The normal person takes for sleep latency is probably around 15, maybe 30 minutes max. You should be asleep.
When you're in bed?
When you're in bed.
15 to 30 minutes
Absolutely.
before you're asleep, okay.
We strongly recommend that people not have televisions in their bedroom.
Mhm.
We strongly recommend they don't have computers, iPads, iPhones, or any of that, because that has adverse consequences in and of itself. So these computers and cell phones emit blue light.
Mm-hmm.
Blue light suppresses melatonin, which is secreted from our brains
Mm-hmm.
to make us want to sleep, to promote sleep.
Oh.
So you're suppressing your melatonin, and there's a very complex connection between the back of our eyes and the pineal gland that controls that, and that's suppressed by blue light.
Interesting.
So we tell people, don't be doing any of that stuff in the bedroom, don't have bright lights on. If you can't fall asleep, get out of the bedroom, go downstairs, dim lights. If you want to watch TV downstairs, fine. When you think you're going to doze off, then go to bed,
Yeah.
lights off.
How long before bedtime should you avoid any type of blue light, any type of stimulation for that?
I usually tell patients about an hour, hour and a
Yeah.
half, yeah.
Okay, okay. And that all falls under the category of sleep hygiene, which is what
Absolutely.
we discussed, so kind of the behaviors that precede sleep that could contribute to your quality and time of sleep. What are some other things that you can identify?
Try to minimize alcohol intake and caffeine intake. So alcohol, while a lot of people will consume alcohol to go to sleep,
Yeah.
as you metabolize the alcohol and your blood alcohol levels start to fall, some of the metabolites actually are weight promoting.
Mm-hmm.
That's why a lot of people will say, I go to bed, I may have a drink or whatever, and I'm up in 3 or 4 hours. Those are the weight promoting metabolites of alcohol that are affecting
That
the brain.
is so common. And, in terms of primary care,
Yep.
we hear two things. And I read this great article, and probably about a little over a year ago, about one of the common things we see, and I know you see general patients too, is, my memory is, I feel like I'm worried about my memory. I may be forgetting more. I don't think I can remember as much. And what this article was talking about is that there is a natural decline in our memory in terms of beginning probably early 60s, a natural, but really it's sleep. There are many things that are affecting memory, and it is often a combination of people not sleeping great for either they have a television in their room or the phones or the computers, self-medicating with alcohol to help with it. Then they go to their doctor, who tries to think they're helping them in a way, and they're giving them perhaps a prescription for a sleep aid, whether it's an Ambien, and it's this kind of, recipe for trouble, because then they're not sleeping well, they're over-medicated, and it's affecting them cognitively. And I have so many patients who drink to have a drink or two to see about helping them go to sleep, and it seems counterintuitive to tell they just don't see it. But so that's right. So it's true. It disrupts your sleep.
It's paradoxical, yes.
Yeah.
And what about coffee intake? So I know that you metabolize caffeine differently as you get older, and I think that sometimes we can identify that in elderly people who have always had a cup of coffee at noon every day, and now maybe it's disrupting their sleep.
I recommend no coffee with caffeine after 3 p.m.
3 p.m.
So caffeine blocks what we call adenosine receptors. Adenosine is a chemical that many people are familiar with and is part of ATP, but as the day goes on and we're awake for long periods of time, the adenosine starts to build up, and that's going to promote sleep. Caffeine, on the other hand, blocks that receptor, and so people can't sleep, and that's the way caffeine works in the brain.
What about eating? Does that disrupt your ability to go to sleep if people have a late meal?
If they're having reflux symptoms,
Mhm.
it's not really a good idea.
Okay. But in terms of I know some people work late, they come home from work, they're hungry, they eat. That doesn't necessarily, kind of
Not
prevent you from
usually.
going to sleep.
No, it's the types of foods more. If you're eating spicy meals
Okay.
and things that have a lot of MSG in it, well, maybe that'll promote that because of glutamate's a stimulatory hormone.
Mm-hmm.
We have a question from Linda, who had commented that she's sleeping about 2 hours a night. She had a sleep study that said she was okay, and is also wondering about melatonin as an over-the-counter supplement, and kind of your thoughts on that.
Well, sleep studies going to be okay for insomnia. In fact, if we're talking about insomnia, sleep studies are not indicated.
It's good. Okay,
Okay,
perfect. Yeah, let's
good.
talk about that.
It's
Yeah.
classic board question, okay?
Okay.
You don't need a sleep study if you're evaluating a patient for insomnia. It's just not helpful. Unless you're thinking maybe there's some sleep architecture issues, but that's rare. The answer is you don't need a sleep study.
So that's if you just can't sleep.
If you just can't sleep,
you don't need a
it.
sleep study.
You don't
Okay.
need a sleep study for the vast majority of patients.
Okay.
I mean, sleep studies, what you're looking for is some certain things. You're looking to see about breathing patterns, maybe some sleep architecture. You're looking to see if people are having seizures during their sleep. But sleep studies are not really helpful for insomnia. That being said, you try to do the usual things. 2 hours of sleep at night is very abnormal. You can try the melatonins to start with.
And what's a dose? So what's the dose that you recommend for that? Because there is some kind of discrepancy about
We
that.
go 4 to 6 milligrams.
Milligrams.
So
Okay.
5 milligrams is the sweet spot.
Okay.
Now, with respect to the insomnia, people want to reach for a sleeping pill.
Mm-hmm.
The data on the effectiveness of these sleeping pills for chronic insomnia, that is, people are having symptoms for more than 3 months, is horrible. They don't work over the long haul for the chronic insomnia patients. The most effective form of therapy for chronic insomnia is something called cognitive behavioral therapy of insomnia. It's basically trained clinical psychologists who specialize in the types of sleep hygiene stuff and things that go on with keeping people awake at night. That is by far and away the most effective way of
Above and
treating.
beyond any type of
Above and beyond.
prescription.
Do we have any of
that you
those
provide.
locally that we work with?
Unfortunately, they are few and far between. The closest one that I'm aware of is in Fall River, and other than that, there's another one in Providence.
What's the name of the one in Florida? Do you
I
remember?
don't recall off the top of my head.
We can research that, and for the woman who wrote that in, maybe we can get that back to her
Yeah.
in terms of that answer.
And then, are there ways to naturally increase your melatonin levels through food, or is it generally a supplement?
No, it's supplement and minimize your blue light in the evening.
Okay.
So this actually is, if you look at blood levels of melatonin, there's something called a dim light melatonin onset that occurs somewhere around 6 or 7 o'clock at night, and then you'll start to see the melatonin levels rise.
Ideal temperature to sleep in, you know, in terms of, is it cooler, better? I mean, I think that's,
Cool down to go down, warm up to get up.
I like that.
That was a way I remembered it for the boards.
So a couple other questions here. We touched upon sleep studies not useful for insomnia, but actually being useful kind of diagnostic for a couple of other things. What's the difference between an at-home sleep study, how that's conducted, and then one that's done in a sleep lab?
Okay. That's a good question, because the majority of sleep studies these days are being done at home.
Okay.
Unfortunately, it's being driven by insurance companies.
Okay.
They are far less expensive than in-lab studies. So with an in-lab study, we measure people's breathing, we have continuous EKG monitoring, oxygen monitoring, all of that stuff, but and breathing patterns. In addition, however, we're actually doing brain waves. So people have all kinds of little electrodes and goop on their head, and we're actually looking at EEGs. In the home setting, that doesn't occur. So if a patient comes in to the lab and has an in-lab sleep study at night, I know if that patient slept. I know to the minute how many minutes of sleep that patient received, and I can look at the architecture of that sleep in stages. In the outpatient setting of the home studies, I have to assume that the person slept because they don't have the brain waves. It's only measuring a few channels, being the oxygen and respiratory patterns, and that's about it.
Okay. So for you to diagnose any type of sleep apnea or issues, which is more useful?
We do a lot with the home studies. If I have patients who I'm not convinced don't have sleep apnea, there's some data out there that says that one sleep study may not rule out sleep apnea, then I'll bring them into the lab. If I see patients in the outpatient setting that may have central apnea on a home study, then I'll bring them in to confirm that, because I rely more on the in-lab studies.
A couple of other general questions that we kind of touched upon. Lynn writes, I fall asleep around 11 p.m. but wake up 3 or 4 hours later, wide awake, and brain is ready to go. So like you said, kind of moving the sleep time back seems to be pretty late. And she can't get back to sleep. Not sure if she's having restless leg twitching that's waking her up. Could you
Yeah, so
speak to that a
there
little?
are two forms of leg movement disorders that we see with sleep. One is restless legs, and the other is periodic leg movements. Restless legs tends to keep people up at night, so if that individual is having those types of symptoms at night, yeah, it's very possible, and there are ways we can treat that. Same thing with periodic leg movements and periodic leg movements can cause arousals as well.
In terms of like differentiating with patients, I always tell them, because everyone, not everyone, but people tend to think they have a restless leg, and you know, I tell them that restless leg is that your legs hurt, and the only way to often to kind of relieve the pain is they move them, correct? Versus the periodic limb movements is when their legs are bouncing all over the place involuntarily, right?
When they're asleep.
When they're asleep.
So I like to distinguish the two. Restless leg movements for most patients is a problem of wakefulness,
Mm-hmm,
whereas periodic leg movements is an issue with sleep.
okay.
Okay? I mean, you see these little twitches. We also measure muscle movements when we have patients in the lab. We actually see the twitches and everything. It's classic. With restless legs, though, it's this urge, and that's the mnemonic that people use. You have this, as soon as you slow down at night and sit down and lay down, you start to get this uncomfortable feeling in your legs. Sometimes people call it like something's crawling under my skin. And it's uncomfortable, and the only way to really get rid of it is to get up and walk around. And as soon as you sit down again, or lay down again, it comes back. Sometimes associated with alcohol, sometimes it's associated with iron deficiency.
I was just gonna bring that up, yeah.
Yeah, so patients who have restless legs and probably periodic leg movement should have a ferritin level
Yeah.
to assess them.
So I was gonna say that we should, if you have those symptoms, make sure you've seen your doctor and ask about checking your iron levels, because, and often iron is a treatment as well, that depending, they may or not be anemic or not, but sometimes a little low dose iron helps people kind of get over those symptoms,
Yeah,
correct?
that's a great point. So we talk about iron levels in these patients of, if you see it less than 50, you should treat them, and that's relatively normal.
Normal
Normal,
iron, yeah.
Yeah, so it's a different set of rules for when we're treating restless legs.
Restless leg. We had another question about magnesium and calcium supplements helping with sleep deprivation. Have you seen any correlation
There's
with
no
that?
great data on
Okay.
that.
A common sleep question we see in the office, and you probably see too, is leg cramps as well, or nocturnal leg cramps. And I try to encourage people to stay hydrated, make sure they're drinking enough water, some stretching before bed to make sure that you kind of move the lactic acid and stuff around. And then, some people like, for the muscle cramps, a magnesium, or, is that we're on the right
we
track
do
there?
Either that, yeah, absolutely. And the other thing you can do is I try to get them to get some quinine. So,
Oh, okay.
So tonic water,
Tonic
like
water,
8 ounces
yeah.
of diet tonic water, because that's a lot of sugar if you get the regular stuff.
Okay.
And give them a little
Is,
tonic water.
is there any truth, so when I used to work in the hospital, the older patients, when they would have leg cramps, would say, I just need to put my feet on the cold floor. Is there any?
Yeah, I think that's got to do with stretching the gastrocnemius
Okay,
muscle.
okay. Couple of questions here, general questions, one from Nicole, one from Andrea, about just going to sleep on time, not wanting to take pills, but just waking up and can't seem to shut their brains off. Would that be more of the cognitive behavioral
Bingo.
therapy route? Yeah,
Absolutely. So
okay,
what's happened is
okay.
when these people are waking up in the moonlight, and what then happens is they start to perseverate. I got to get back to sleep. I got to get to work in the morning. How am I going to function? When you start in that's rhythm of thinking and incessant thinking, you're actually sending signals to your sleep centers to suppress sleep. You're waking up.
One of the common things I had read, and I try to tell people, and I can't sleep myself, is you touched on it earlier, is to get out of bed, right? Like lay there for a little bit, but then actually get up out of bed, go to a kind of a darkened room, maybe read, like a little bit of help, but something not super stimulating, and then you get
Absolutely.
drowsy again. Because I think people, they toss, they turn, and they get angry, and is that right? Like,
That's absolutely right.
Yeah.
That's the basis for cognitive behavioral therapy.
We had a question come in on the anonymous line about blue light glasses, trying to filter out that light to maybe allow you to use the.
You can try to use them. I haven't seen them work much.
Okay.
There's some data looking at special sunglasses for people with shift work.
So that was, an important, Hannah and I wanted to bring that up, because we have many patients who work not traditional hours, and, what's your advice to them? Because
Get another job.
Yeah, because there's studies, right? I mean, it's not,
Absolutely.
it can affect your health long-term, right?
Absolutely. I believe it's in Holland or one of those countries out there where women with breast cancer, if they work night shifts, that can be considered an occupational related
Risk factor.
Yep.
Absolutely. There's more coming out on that now. So we tell people, when you get home, go to bed. You gotta maintain regularity. We are creatures of regularity.
Yes.
We are creatures of habit, and you gotta continue that. If you work night shift Monday through Friday, and you come home and your bedtime is 8 o'clock in the morning, and you wake up at 2 or 3, well, I hate to break the news to you, you gotta do the same thing on the weekend. Because if you don't, you are going to be tired, because your circadian clock is all over the place.
So that brings up, I think, a point that I see patients, or we see patients who something happens and they mess up their sleep pattern for a while, and I think they disrupt their internal clock, like you're talking about, and then they can have trouble, which is essentially what jet lag is, correct? Like,
Absolutely.
Is that what happens when people are jet lagged?
Yes,
Right?
their clock is messed up.
And then I feel comfortable. Sometimes that's one of the times I do think is perhaps a little bit appropriate to use a sleep aid to get them. I tell them, do this for a week, get back on track and then take it away, right? Like, is that
Yep, and
an
there's a role for
appropriate use for?
absolutely, and there's a role for melatonin in those particular situations as well.
Yeah.
We had a question about trazodone, which isn't a traditional sleep aid, it's an atypical antidepressant actually, but sometimes used in sleep. What's your thought on the efficacy of that?
It's actually a fairly good sedative. So trazodone is an antidepressant. It's one of the older ones. It's never been approved for sleep. Okay. However, it's been used for decades.
It's one of my favorites.
Right. I recommend it a lot to patients. It works primarily by its antihistamine effect because of its, it's one of those older generation antidepressants.
Any questions lined up right now?
We're doing well. One question from Lisa. What would cause someone to wake up out of a good sleep, because their heart starts racing? So maybe palpitations occurring at night. Sometimes we do see this with alcohol use kind of in that window.
That's a loaded question. There are
Right.
so many possibilities. So alcohol is one of them. Waking up from a dream is another. Another would be sleep apnea. So you will see patients who have AFib only in REM sleep.
Really,
So there are all kinds of possibilities with that.
with that.
That's kind of the caveat with the show. We try to tell people that we can try to touch on some of them, but if that's happening, would you say, like, you should probably get that checked out? Talk to your doctor, be
right.
evaluated, because it's a little bit, it's not normal.
That's one of those things where you may want an in-lab sleep study because then you can have an EKG.
Wow.
Let's use that as a segue. We're going to take a short break, and when we come back, let's talk about sleep apnea, if that's okay with you,
Sure.
in terms of signs and symptoms, how we treat it, and questions, and then after that, we'll go to kind of general questions that people may have.
Okay.
By the time I graduated high school, I think I was between 275 and 300. I had to buy my dress clothes at the Big and Tall store. Enough is enough. Southcoast Health gave me the tools, and here I am, with my health. And I was a 46 going into a 48, and now I'm a 30-inch waist. I'm living proof to show if you put the work in on anything that you can get what you want. Take impossible, throw it out of your vocabulary.
Hi, welcome back. Welcome to Health Plus Weekly. For those of you who may just be joining us now or joined in late, we are working and have the privilege of Dr. Curtis Mello, local physician specializing in pulmonary critical care and sleep medicine. And tonight he's kind of talking to us about sleep, sleep disorders, recommended sleep. We were just talking a bit about insomnia. And now we'd like to move into sleep apnea. We see it in our patients every single day. I'm not sure I'm sure you know this, but I'm sure it's tremendously underdiagnosed. So first of all, can you explain a bit about what it is and what causes it, and what may be some symptoms that may kind of impress people to get checked out to be evaluated for it?
Sure. So the most common form of sleep apnea is obstructive sleep apnea. So sleep apnea in general is basically you stop breathing when you sleep. That's what apnea means, okay? And it can either be a case where you obstruct, where the airway closes off while you're sleeping, or you just stop breathing for no other reason. And that's usually related to drugs or some issues with the brain. So what we see most commonly is obstructive sleep apnea. So this is a condition that occurs I would say the majority of time in snorers.
Okay.
Okay, so we breathe pretty much on a negative cycle. So when we take a breath in, our diaphragm is going down, our chest wall is going out, and air is flowing in because now we have a negative pressure inside of our chest. That's how air flows. So we have a tube now with negative pressure, and we have all this soft tissue over here. Atmospheric pressure is 0, but the inside of that tube is negative, so there's a gradient to shut everything down, right? So people lay down with that narrowed airway, they snore until they suck their airway shut. And then they start to make efforts to breathe again. And then what has to happen is a signal is sent from the brainstem because of certain chemicals that build up to the top of the brain, tighten up those muscles, wake up, and then they start all over again. So this happens multiple times a night.
Like how many times? It's amazing. It amazes me, but when you look at this.
I have, so the way we look at it is how many times this happens per hour. And that's how we diagnose it, and that's how we gauge the severity of sleep apnea, obstructive sleep apnea. So less than 5 events per hour is normal. So 5 to 15 is mild, 15 to 30 is moderate, anything above 30 is severe. I have patients 120, 140.
An hour.
An hour.
Wow.
Yeah. Stopping
Oxygen.
breathing, going through that an hour.
They're exhausted, they're sleeping in my waiting rooms, they're sleeping in my exam rooms while they're waiting for me. So the end result of all of this is you fragment your sleep. You never get good quality sleep. And as a result of that, people are tired during the day, they don't feel rested when they wake up in the morning, they have headaches when they wake up in the morning, they're going to the bathroom multiple times at night. You see leg edema, swelling of the legs, very commonly, and then you just get into the whole issue of sleep deprivation and cognitive dysfunction. It's not uncommon for neurologists to send me patients because they've been sent patients by primary care doctors thinking maybe this person has Alzheimer's disease or dementia. And the neurologist is not convinced either. They say, well, maybe this person has sleep apnea. And very commonly, these patients actually are sleep deprived.
Mm-hmm.
And you get them on CPAP therapy, and they do better.
What are some of the other long-term negative health effects of sleep apnea?
So,
Untreated sleep apnea.
untreated sleep apnea. So the highest risks are people with moderate sleep apnea and males from, I believe, 55 to 70.
Mm-hmm.
But the big risks are stroke, atrial fibrillation, which is an irregular heartbeat that can lead to stroke, high blood pressure, and then all-cause cardiovascular death. So it's not uncommon to hear of people dying in their sleep from sleep apnea.
It's one of if you're seeing your doctor, when we see patients who have resistant hypertension or they have, first of all, for people who are just newly diagnosed with high blood pressure in terms of thinking about what may have caused it, but also in patients whose blood pressure is not easily controlled with 1 or 2 medications, I always think about, kind of going into, their sleep history,
Sure.
right? Because it's common.
Yeah, so if you see people with what we call refractory hypertension that's difficult to control, they should be studied for sleep apnea because of a lot of the hormonal changes that are occurring when those apnea episodes are occurring.
Mhm.
So yeah, I agree with you there. The other thing would be AFib. So with this
Yeah.
AFib, the majority of those patients now should have a sleep study.
Neck circumference.
Yeah.
Has a role with this, right? In terms of you should be worried about perhaps if your neck is a certain size.
The risk goes up once the neck circumference is greater than 16.
It is 16.
Yeah,
For men, and it's a little bit less for
a
women.
little bit
yeah.
less for women.
Yeah. What, you mentioned mild, moderate, severe sleep apnea. When do you start somebody on a CPAP machine?
Good question. So there's no debate with moderate and severe sleep apnea.
Okay.
Those people should ought to be treated. Where the debate has arisen is patients with mild sleep apnea. And some patients with mild sleep apnea are not terribly symptomatic. But what we do know is if you have mild sleep apnea and if you have certain comorbid conditions such as heart disease, atrial fibrillation, difficult to control high blood pressure, diabetes, history of stroke, well, even mild sleep apnea will adversely impact you.
Right.
So those patients with comorbid conditions should be treated for mild sleep apnea irrespective of symptoms. Okay?
And should they be monitored in the future for progression towards, moderate or severe? How do you kind of?
Well, it depends. We watch them, so a lot of these people, nowadays with these CPAP machines, I know when they're on CPAP how many times an hour they're stopping breathing at home.
Because it's feeding you information, right? The
Oh, yeah,
machines.
we do that. So we see our patients in the first year 3 times, and then after that, we see them yearly.
That's a great question, because I think a lot of our patients fall out of that. They're not always seeing you when they got prescribed, and they haven't seen a doctor in years, and they have their machine. So if you are on a CPAP machine for sleep apnea, you should probably, you should see you're checking with your sleep specialist at least once a year, which
At
is
least once a year, absolutely.
Okay.
There's a lot of data we're getting out of these machines now that we never could before. I see a lot of patients that come to see me, have been on CPAP for 5, 10, 15 years, have never had a follow-up exam.
Okay.
They were given the machine and sent on their way.
And there's new technologies in the machines too. That's the other thing. I mean, a lot of our patients struggle, or had a bad experience in the past with the machine not fitting right. But now there's lots of new technologies, masks, and different ways to make it more comfortable. Correct?
Yeah, there are a lot of patient interfaces or masks that we use. The technology's a lot better. These machines are a lot smaller, a lot quieter. We even have smart machines now that we call APAP, so they're not CPAP machines, or we can convert them to CPAP, but they basically will sense the airway resistance and figure out if the patient needs a higher pressure, and will give that higher pressure.
And what do the machines do? Because some people necessarily don't understand. Like, how do they help you breathe better, and what happens?
Think of it as a pneumatic splint. So remember I said the airway gets negative, so, and then the driving pressures are coming from the outside to collapse everything. All you're doing is putting positive pressure in that airway to blow that soft tissue apart to keep your airway patent. That's how it's working.
Good question. What's the difference between a CPAP and a BiPAP machine from Jennifer?
Okay, so CPAP stands for continuous positive airway pressure. That means that if I set the pressure, for example, at 10, that air is going to come into that individual at 10 and stay at 10, and that individual then has to blow out against that pressure of 10. BiPAP, or what's called bi-level positive airway pressure therapy, is a little bit different. So we typically tend to use that for individuals who require higher pressures, okay? So let's say they need a pressure of 18 to keep their airway open. Well, it gets a little difficult to blow out against a pressure of 18. So we can then tell the machine that once they sense that the person's going to start to exhale, we can drop the pressure to like 10 and make it a lot easier for them to breathe.
Okay. Anything in the queue? Last week I got overexcited and I think I hogged the guests, so I want to make sure I answer everyone's question. So I want to make sure I respect people sending in questions before I keep going.
Oh, we're doing well here. A comment from Rena, he says you're an awesome doctor, so that's always nice. We have a question from Steve. If you are an open mouth breather, can you use a nasal cannula instead of a full mask, or is the full mask better to use? And that's the specific
For
type
CPAP.
for CPAP machine.
Some patients get, what they describe is that the airway sucks tight or shut.
Okay.
But the majority of people who sleep with their mouths open usually have to go to a full face mask. There are people out there who tolerate it and learn to close their mouths.
Is there any role, we've seen people using mouth guards to kind of reposition the jaw and the back of the throat. Do those have any role kind of in mild sleep apnea, or where would you, or if you would recommend them?
There's a certain anatomy that I think that it works best in, and that's people who have a shorter mandible, or what we call retrognathia, so they have an overbite.
Okay.
Those people can get by with what's called an oral mandibular advancement device. They are, there's a lot of them on the market. What most of us recommend is if you're going to go down that road, go see a dentist who specializes in this, because you really need a custom mouthpiece.
If it's a dentist who would do it.
Yeah, it's a dentist. I mean, they're expensive, and most insurance companies don't pay for them.
Because there are people who feel like they can't tolerate the mask. So in your experience, how do you help those people in terms of, is it adjustment? You tell them to come back? Because we see that a lot. Oh, I couldn't tolerate it. I tried. It woke me up. And
So-
we try to impress upon them the importance of treating the disease, because it's a bit of like a high blood pressure, silent, killer in a way.
What our sense is as sleep specialists, and some of my colleagues who are also into the sleep academic side of things, we've been discussing doing this study, because our sense is if you get these patients to go see a sleep specialist, the compliance is much higher. Because we tend to work with patients and get them on the right mask. I mean, my strategy is usually, I'm not going to pick the mask for you, you're picking the mask. And the reason being is there are studies out there that show that if the doctor likes the mask, patient doesn't like the mask, doctor insists on what he wants, patient doesn't use the mask.
Use it.
Yeah.
Right.
Right? So, We really work with patients that way. I would say that our compliance is somewhere in the vicinity of 90%.
Okay.
So those people that don't tolerate CPAP, we may try BiPAP on them. We may try mask. Some of these people can get by with what we call positional therapy, where they're only having their apneas when they're on their back. So they're only snorting when they're on their back. So we'll, get them a device that keeps them on their side.
That's ironic. I trained at Temple down in Philadelphia.
Yeah,
Big
I know
pulmonary
the guy.
department. Yeah,
I know what you're gonna talk about.
They would take T-shirts and sew a tennis ball into the back of the shirt
Yeah.
behind the shoulder blades, so that it was just enough where people would be uncomfortable and they roll off their back onto their side. So there's some validity to that, you think?
Absolutely.
Yeah.
No, clearly that's the case. There are 2 fanny packs on the market right now to keep people on their sides, and there's a pillow on the market as well to keep people on their sides.
Okay.
There's a follow-up question to the difference between the CPAP and BiPAP machine. You said it's for higher pressure, the BiPAP, but it's also used for some end-stage COPD,
End-stage
to help.
yeah.
So what would be the scenario where you would use it for COPD?
Yeah, typically those patients, for Medicare to pay for BiPAP for COPD, they have to have low oxygen levels and they have to have elevated carbon dioxide levels. And the way the BiPAP works is it keeps positive airway pressure and helps what we call minute ventilation.
Because in terms of breathing, we break it down to, we get oxygen in and carbon dioxide out. And so what happens when people who have, and correct me if I'm wrong because I'm talking to a pump, but I mean, that gas exchange becomes impaired, right? Because
Absolutely.
their lungs are less flexible and don't move as well.
Right.
So the 2 different pressures bring the oxygen in and help flush out the carbon
Yeah.
dioxide. Is that right?
Right.
Yeah.
And the other thing that BiPAP will do for patients as well, because of its positive airway pressure, it decreases your work of breathing,
Right.
so it makes allows respiratory muscles to rest overnight.
A question regarding humidified airway pressure. St. Michael says that his father uses a heated water machine and has adjusted the humidity several times, and he still wakes up with a very dry mouth and throat. I imagine that's a common complaint that you have.
Very common.
So any suggestions or pointers to kind of combat dry
Yeah,
mouth?
you have to understand how much leak you have in the system. If you have a lot of leak, and the new devices will measure leak for us, and that's part of what we talk about.
Meaning airways,
Air
getting out,
escaping around.
not into your mouth.
That will certainly make you dry, and other times people have not totally turned up the humidification
Okay.
systems. I see a lot of patients that have no idea how to do it.
Okay.
So would you recommend that they
Talk
come
to
in
them.
and
Yep.
have the machine looked at?
Yep.
Okay.
Surgery for, is there a role for any surgical procedures for this?
Yeah.
Some people, I have patients who ask me about that.
Yeah, the data on surgery is not that great.
Mhm.
It's probably effective in about 50 to 60% of patients. You can improve your odds if the surgeon is careful at who he or she takes to the operating room. So if you have a certain type of anatomy that would, open up that airway, that's fine to do it for. But the majority of patients, the answer is probably not.
Okay.
There is a new procedure out there. So typically, they're going to snip back the soft palate. They're going to take out your uvula, and if you have big tonsils, they're going to take those out as well. So that's the standard procedure. There are some procedures where they can advance your tongue, called a genuglossal advancement. And the latest thing on the block, and this is only for patients reserved for severe sleep apnea who have been refractory or intolerant to positive airway pressure therapy, and that is they actually put in, it's almost like a pacemaker where they put a box into your chest, wire going up into your
Really?
airway over here, and it senses the breathing and will cause your airway to open. And I have one patient who's getting that done right now.
Is this a weight-related phenomenon in terms of if you lose weight, does it go away?
Yeah.
Can you cure it?
Yeah,
Do
can it go
something to
away?
it? Yes.
Exactly.
Yeah.
Yeah, so if it's a weight-related phenomenon, the answer is yeah, it can go away if you lose the weight. So if you look, the best data we have is in the bariatric surgery patients, right? So those people are really overweight.
Mhm.
The vast majority of those patients have obstructive sleep apnea. They're on CPAP. And if they lose a substantial amount of weight, we'll actually study them in about a year. And about 65% of them or so come off of CPAP.
Do they really?
Yeah. So for the majority of patients, I would say, yes, it is weight related. There is a subset of patients, though, that are thin that still have sleep apnea.
Exactly.
And it's just the way the
And that's
airway's
an
made.
anatomy.
You know, and it tends to run in families in those individuals because they all look alike and have the same type of face
Okay.
or anatomy.
Interesting.
Symptoms, again, for people who are turned in or missing that may lead you to believe or suspect that you should be, talk to your doctor about it or reach out to a sleep specialist. And the things I ask patients about in terms of their symptoms is, like, do you feel rested when you wake up? We should feel rested, correct?
Yes.
Do you fall asleep easily during the day? I try to ask them, do you nod off and different things? And, and I asked them about what their neck size is. I thought it was 17, so it's 16. So if
16.
you measure your neck and it's bigger than 16, is there anything else that are those accurate?
Yeah, those are some of the symptoms. Snoring at night, witnessed apneic episodes.
Okay.
So in other words, my wife was telling me that I stopped breathing
Yep.
and I'm scaring her.
We see that a lot, yeah.
Morning headaches, right? So that's another thing. Sometimes unexplained swelling of your legs is a sign of
Okay.
it. Falling asleep behind the wheel of a motor vehicle
Yep.
is a big
It's a
one.
big one.
Why do, you touched on it before, urination. I have some people who complain about, boy, I have to get up and you're chasing the prostate, but there's a link between sleep apnea and you having to pee at night.
Yeah,
How come?
that's because of all the adrenaline changes.
Is that what it
occur.
is?
Yeah, because your blood pressure is skyrocketing when you're having these apneic episodes.
So you're feeding your kidneys, it's,
Yeah, so
creating urine.
there's this thing called normal people have this dipping phenomenon with sleep, with blood pressure. But one of the problems with patients with sleep apnea, particularly those who are developing hypertension, have this non-dipping phenomenon. Your blood pressure stays elevated. Well, then you have more. It's more of a sympathetic drive, if you will. Your sympathetic nervous system is kind of on overdrive, and that's why you're urinating more.
Is there a best position to sleep in? Like, in terms of backside? It's not like a one-size-fits-all, but in general, should we?
People will snore less if they're on their sides.
Okay.
So I tell people, try to stay on your sides. I would say at least 50 to 60% of patients, their sleep apnea, as well as snoring, is worse when they're on their backs.
Okay. So it's probably better to be on your side
Yeah.
if you can do it.
Yep.
We had a question about an individual with mental or physical disabilities and wearing a CPAP mask
That's
that
a good
won't
question.
keep the mask on. Have you encountered any strategies for?
So we have a number of our patients who have Down syndrome. And a lot of them, because part of the syndrome is something called macroglossia, where they have a big tongue.
Okay.
And a lot of those individuals actually have sleep apnea. And we've been fairly successful at getting these people to use the machines.
You find- okay.
We have about 10 minutes left before the end of the hour. I was wondering if you could just talk a bit about, the sleep center that Southcoast has, who, the services you offer for people. Obviously, you do a lot of sleep studies and CPAP, but, and what services we offer for people who may or may not know, and who should be reaching out, and what type of people do you help on a daily basis?
I mean, the majority of patients that we see are coming in at the request of their primary care physicians because of reports of snoring and witnessed apneic episodes with difficult to control high blood pressure. We see a lot of patients from cardiology for patients who've had atrial fibrillation. Sometimes patients that are in and out of heart failure, it's because they're not being treated for their sleep apnea. I get a lot of patients from neurology. There are certain neurodegenerative diseases that have some unusual sleep disorders. For example, there's this thing called REM behavior disorder. Earlier in the hour, I told you that people that are in REM sleep are paralyzed. Well, with REM behavior disorder, you lose your paralysis and you act out your dreams. So these are particularly
Oh my God.
particularly men in their 70s and 80s. They're fighting, they're hitting their wives, they're falling out of bed, they might even jump out of windows. They're hurting themselves. And that there are these dreams of things are attacking them all the time. That is and you make that diagnosis, that's another reason to do an in-lab sleep study, because you got to prove they're in REM and then they've lost their paralysis. When you see that, one of the problems with that is linked to several neurodegenerative diseases. For example, Parkinson's disease and Lewy body dementia.
As precursors prior to?
Absolutely,
Okay.
and that can precede the onset of these diseases by as much as 15 years.
Really? Wow.
And unfortunately, there's nothing that we can do to prevent the development of those neurodegenerative diseases. We have great therapy for treating the REM behavior disorder and keeping these men and sometimes women safe. But we get some from neurology for that. We see people that are forgetful, question of dementia.
A question from Tricia, who's just tuning in. Could you describe the physiological effects that obesity has on sleep apnea? What about being overweight contributes to developing sleep apnea?
Well, there are several things. So first of all, people who are obese will have what we call hypoventilation. They just don't take big, deep breaths.
Because they're fighting against their
Well, you
their
have
body
all that weight and
Yeah.
your diaphragm, you're laying down, your diaphragm is a muscle, it just can't move against
Okay.
the weight. So that's one thing. The other thing that happens with people who are obese is you also accumulate fat and excessive tissue in the back of your throat. And so you're starting off with a narrower airway
to begin with.
than someone who's not obese. So you don't have any room for any collapse of the airway, like a thin person would.
We have one kind of general question, just switching gears a little bit, kind of touching on what we talked about last week from Sarah. How often, maybe in primary care, and you do some primary care as well, do you address dietary choices in relation to risk for kind of treatment of chronic diseases? And what are some pointers that we advise on? I know in our practice it's all day, every day for a variety of different chronic illnesses.
I'm happy to field that, in terms of, I think there's I'm sure you do, there's a tremendous link between what we put in our bodies from a nutrition standpoint and, diseases that can afflict us. Certainly we know, just talking regarding weight, that obesity can put you at higher risks for, high blood pressure, diabetes, sleep apnea, cancer. Those are linked. There's, in terms of heart disease, we know diets high in saturated fat, increased risk for chronic disease. There's certain foods, that may or may not increase inflammation for people who have, so you can delve into that. So ideally, I think it should be a cornerstone of your medical care that you're talking about your diet and your nutrition. And I think, I'm biased towards more of a plant-based diet myself. I think that if you look at the areas in the world people live the longest, they're eating primarily a plant-based diet. And so my patients who see me definitely know I'm slanted towards that. But there are all different types of diets for different people. There's not a one-size-fits-all, which is what we were talking about last week.
I would add exercise, so.
Oh, yeah, absolutely.
For those people who know me, I'm an exercise freak. I believe in this content. I do it myself 5-6 days a week.
Yeah.
But even my end-stage COPD patients, I get them to exercise. Because you see a deconditioning effect in these patients when we study them in the exercise lab.
Mhm.
The less they do, the less they're capable of doing. And
Yep.
it becomes a vicious cycle. So muscles atrophy, the respiratory muscles atrophy, the accessory muscles to breathe all kind of shrink on down and get weak. You got to do it. You got to
You
get
have
up
to
and
do it.
move.
I actually had a great talk a couple of years ago in terms of how we're meant to move. Like from an evolutionary standpoint, we are not too far removed where we are walking 8 to 10 miles a day in terms of food, working, in that the advantages of technology in modern society you're greatly outpaced evolutionary changes in our body, and that by us being sedentary, and not moving, it's like sitting is the equivalent of smoking. And there was a great article in Runner's World a couple years ago, I think it was, like, we're sitting is the new smoking.
Yeah.
We are meant to move.
Yeah, I used to have a partner who used to work with us. He wanted a new desk put in his office that actually is a desk that he had to stand up to type and do everything on. Because he felt that sitting was probably one of the worst things we could ever do.
Mm-hmm.
And had quite a data to back it up.
Yeah.
One last question coming in, a lot of, Susan, getting a lot of sinus infections wearing a face mask. Any suggestions in terms of how frequently should you be cleaning the CPAP machines, and other suggestions for kind of sinus rinses?
So at least several times a week that machine should be cleaned. The filters need to be cleaned on a regular basis. The mask should be changed. Tubing should be changed. Sometimes the machines are contaminated.
Okay.
I've actually seen a case of Legionnaire's disease that we were able to culture right back to the machine.
Wow.
So making sure that people are using distilled sterile water. And if they're still having problems cleaning the machine, there is a device out there that is not covered by insurance company, costs just about $300. But basically, you just put the stuff into the little box and it cleans it overnight for you and sterilizes it. It works
Okay.
very well. Most of my patients buy it not out of necessity, but for the convenience factor, and they feel that the $300 is worth the
Worth
convenience.
it.
Yeah.
Question from Nicole. Could you please differentiate between clear-way apnea and obstructive apnea? I'm not familiar with.
Central apnea.
Okay.
So what we're talking about is central apnea versus obstructive apnea. Obstructive apnea, your airway obstructs.
So by all those physical
What I
mechanisms
was
that we talked
talking
about
about, right.
before.
Central apnea, you just don't take a breath.
Okay.
So you can have that with certain heart conditions, certain brain conditions, and particularly with patients on chronic opioids, we see it all the time in the lab.
Okay.
So it's one of the, when we see patients who are exhibiting central apnea in the lab, one of the first questions we go back and ask is, are they on opioids?
That's part of the main reason of overdoses, for opiate overdoses. It depresses your central respiratory drive, correct?
Absolutely. So these people, while they may be functional during the day, getting this, they're exhibiting respiratory or breathing abnormalities, ventilatory abnormalities at night.
Yeah. We had Dr. Holly Alexander on talking about opiate addiction and the catastrophe, and the epidemic that it is, but it's a good point. The accidental overdose rate from those medications, people taking them correctly, not abusing them, is high, and that's one of the things I think they forget, that you may be taking your dose during the day and okay, but as you sleep at night, your body requires it, and you go into these different phases, and these medications are long-acting, patches especially, that you have this central respiratory depression that
Yeah,
and
and
they
some
don't
of
wake
them,
up.
and some of these people are either consuming alcohol, which is also a respiratory depressant, or they're taking benzodiazepines on top of all of this, and we really see a lot of that, central apneas.
Okay.
Well, we want to thank you very much for taking an hour out of your night to come talk to us. The questions were, obviously, it was a hot topic. It was, I think, the most directed questions regarding a topic, so we may ask you to come back on because I think, sleep affects many of us. So to kind of recap that, we should be getting probably about 6 to 8 hours of sleep, most of us for adults.
Mm-hmm.
We should try to go to bed roughly around the same time every night and kind of get in a bit of a habit. These are horrible for us before we go to bed, is that right? That we should not be
Yes.
checking our emails and different
No.
things as we're in bed because of, and if we can't stay asleep, we should kind of get up and kind of get out of bed and do something quietly before we go back to bed.
Well put.
And a cool bedroom is better than warm, so we
Yep.
put that to best. Thank you very much.
Thank you for having me.
Thanks for coming.
Hannah, thank you. Josh, as always, our esteemed producer,
Producer.
thank you very much. And again, please share, pass the show along, and tell more people about the show. We want to thank everyone for being involved. We want to thank you for your questions. I apologize for last week for hogging the guest. I hope that, Dr. Mello, we were able to get to more of your questions tonight, and we will see you next week. Sleep well.
I had 2 blockages. I had to have a catheterization and told me that we needed to see a surgeon as soon as possible. Dr. G made me feel like I was his only person that he ever did surgery on. You don't have to go to Boston. You can come right here to Southcoast and get the best treatment. I said to him, Dr. G, I guess I'm going to fall in love with you. He says, I know I'm going to touch your heart.